Hi, my name is Benjamin Kwan, and I'm from Queen's University in Canada. Thank you to Dr. Schmalfus and the program committee for the opportunity to be here. This is session number 4. This is a SAM session. The title is Imaging Techniques. What do I need to consider? Our first lecture will be given by Dr. Nicholas Kuntz, Director of Fellowship Programs, Dean D.T. Mullins Scholar in Radiology Education, Assistant Professor of Radiology, Otolaryngology, Head and Neck Surgery, Department of Radiology and Imaging Sciences, Indiana University School of Medicine. His topic for today is the power of DWI. When should I use it?
Hi, my name is Nick Kuntz, and I'm a neuroradiologist and head and neck imager from Indiana University School of Medicine. And over the next several minutes, I'm going to be discussing the power of diffusion-weighted imaging. When should I use it? So I do have a couple of disclosures to let you know up front. First and foremost, I am not an MR physicist. This really isn't my area of expertise. But what I hope to accomplish is to present to you some really practical and pragmatic ways of applying diffusion-weighted imaging to your everyday head and neck imaging. And I have no financial disclosures as well. I would like to acknowledge several people up front, and that would include Carrie Norris, Sandy Quick, and Jason Parker, all of whom contributed case material and helped to contribute to my understanding of diffusion imaging, as well as to Ilona Schmalfus for putting together this fantastic program and all of the challenges that have gone along with it, with this being our first virtual meeting. So thank you to everyone whose name appears on the screen. I really appreciate it. So over the next several minutes, I'm going to provide a background overview of diffusion imaging and introduce some of the basic types of diffusion imaging, the basic variants. And then most of this talk is going to focus on detailing some of the practical applications. And again, hopefully by the end of this talk, I can convince you that diffusion imaging really is ready for prime time and should be performed routinely for head and neck imaging. So diffusion-weighted imaging is really a workhorse sequence in MRI for neuroimaging, and as we all know, that it really has a predominant role in stroke imaging, but it's increasingly being used for head and neck applications. It's an imperfect tool. It certainly can add value in a lot of instances, but you do need to be aware that it can have some pitfalls and that can generate some confusion. We'll talk about that as part of this lecture. So first I'll talk off just very briefly about some of the principles of diffusion imaging. So diffusion-weighted imaging truly is a functional MR imaging modality. And in essence, what it does is create tissue contrast that's reflective of the random microscopic translational motion of water molecules. So it opens our eyes to some of the underlying physiology that's going on in the human body. Now, it's all rooted in Brownian motion, and that simply means that in a homogeneous system, the movement of water molecules is isotropic. Now, what does isotropic means? It means that the motion is random and it's equal in all directions. So due to these random interactions, these collisions, these interactions, a molecule that starts in one spot, or molecules that start in one spot within this system, will eventually spread out over time, as this animated GIF graphic would suggest. Now keep in mind, the human body is not a homogeneous system, but instead, that translational motion of water is impeded by multiple different structural elements, and that can include things like the cell membrane, axonal structures, the cytoskeleton, blood vessels, blood-brain barrier, etc. And what happens is that results in a preferential directionality of the motion of molecules, what we call anisotropy, this functional preferential direction of diffusion. And that, for instance, in the axons results in diffusion of water molecules down the long axis of the axon. Now, in addition, we can have pathologic states that also result in changes in the diffusivity of water molecules. I think we're all familiar with cytotoxic edema, which is what we are imaging for in the setting of acute infarction, acute cerebral infarction. And so what happens in that case is we have blood flow to the brain that gets shut down, and that prevents the brain from receiving important glucose and oxygen substrates. We can no longer power our Krebs cycle, which means we're no longer generating ATP. And that effectively shuts down the ATP-dependent sodium-potassium pumps. At that point, we have an influx of sodium into the intracellular space, and water molecules follow along with it down the osmotic gradient, becoming trapped in the intracellular space. So effectively what we have is cellular swelling and sequestration of water molecules within the intracellular space, and that's how we get that reduced diffusivity of water molecules in the setting of cytotoxic edema. Another way, and perhaps of more importance for head and neck imaging, another way that we see the effects of diffusion happen to be with the effects of tumor cellularity. So in this graphic, we can see an example of a low cellularity tumor, perhaps a tumor that has low cellular to nuclear to cytoplasmic ratio. And whenever you have a less densely packed tumor like this, the water molecules have an easier time diffusing about the extracellular space. And so you can see all of these arrow vectors indicating relatively free diffusion of water. Compare that to a high cellularity tumor, a much more densely packed tumor. The extracellular water molecules have a very difficult time diffusing about. It's impeded by the dense cellularity of the tumor. And that's precisely what we look for in a lot of cases in head and neck imaging with diffusion-weighted imaging. We use it as a marker of tumor cellularity. I'll touch very, very briefly on some of the diffusion imaging variants. For the sake of time constraints of this talk, I can't really go into detail about all of them. But suffice to say, these are the basic diffusion imaging variants. You have conventional diffusion-weighted imaging, which really doesn't play much of a role in modern neuroimaging, with the exception of maybe some ultra-fast brain stroke protocols, in which you only image in one direction of diffusion, of a diffusion probing gradient. And so you're kind of limited in just the direction of that gradient for looking for impairment of water diffusion. You can have trace and ADC maps, or apparent diffusion coefficient. That's really our current workhorse, in which you have a mathematical model that's taking into account directionality in the X, Y, and Z directions of that diffusivity of water and sort of smoothing it out and sort of averaging out some of the anisotropy or some of the directionality within a voxel due to underlying structures such as white matter tracts. Diffusion tensor imaging we use as well in the head and neck realm, mainly because it's an extension of the diffusion-weighted imaging with trace and ADC, in which you have higher numbers of diffusion probing gradients and higher B-values, which allow you to not just look at the magnitude of the diffusion, but also the directionality of it. Intravoxel incoherent motion, or IVIM, is a technique that is pretty much relegated to investigative purposes currently. It has shown some promise in oncologic imaging. And what you do with IVIM is you take advantage of lower B values, which allow you to take a look at some dephasing that is the result of microperfusion, really at the capillary level in the tissues surrounding and involving the tumor, which allows you to gain some insights about tumor perfusion, really without even having to administer intravenous contrast. It requires some post-processing, and that's probably not quite ready for prime time within the head and neck imaging realm. Similarly, diffusion kurtosis imaging is predicated on the concept that in biologic structures and biologic tissues, the diffusion doesn't neatly follow a Gaussian model of diffusion, and there's some skew away from it. And so by measuring that degree of skew from the Gaussian model, you're able to predict the underlying degree of structure in which a tissue might have. And so there is some role, or there's thought to be some role as well for oncologic imaging, but that's still also largely in the investigative realm. So for the rest of this talk, we're going to focus mainly on the things that are widely applicable to current imaging, and that specifically is involving trace and ADC, as well as diffusion tensor imaging parameters. So from here on out, we're going to focus on very practical applications of diffusion imaging that you can do every day in the reading room, and things that I think can add value to your imaging. And these, to me, are really the current practical applications of diffusion imaging. We'll first start off by talking about prediction of benignity versus malignancy. So in this regard, the diffusion imaging is really a valuable adjunct to the conventional MR pulse sequences. And in general, malignant lesions tend to have lower mean ADC values compared to benign lesions. That's not a perfect paradigm. Certainly there are false positives and false negatives that can occur, but in general, the more cellular a tumor is, the lower the mean ADC, and malignant tumors are more likely to have more of a cellular substrate, so they tend to have lower ADC values than benign tumors. Importantly, you have to keep in mind that there is absolutely variability in terms of quantitative DWI measurements between vendors, even between scanners within the same vendor, as well as depending on parameters, such as higher field strength magnets, higher numbers of diffusion probing gradients, higher B values. All of those things impact the quantitative mean ADC measurement. So here's how it works, and this is based on multiple prior papers. This is sort of the accepted way of doing this. But when you do quantitative mean ADC assessment, you make a freehand region of interest about the lesion in question. And you want to include the most solid or suspicious parts of the lesion, sparing the peripheral 1 to 2 millimeters because you may get some partial volume averaging of adjacent structures. And you also want to avoid the cystic or necrotic regions of the lesion because those can sort of fictitiously drive up the ADC value. If you have a cystic area or necrotic area, water can more freely diffuse within that than it can within the solid area. I show you this slide to show that there's really been a lot of work that's gone into this realm and a lot of prior publications that report different mean ADC values of benign lesions versus malignant, as well as proposed malignant thresholds. And what I want you to take from this side is just an appreciation for the heterogeneity and sort of the variability of some of these thresholds. So you can see, bottom line is, the lower the mean ADC value, the more likely it is to be malignant. As far as picking an absolute threshold, as you can see, it really varies depending on the study, the patient population, the scan parameters, and accordingly, the sensitivity and specificity of these is quite variable as well. But here's an application of how this might work. So as you take a look at this lesion, we have this avidly but heterogeneously enhancing central skull-based mass involving the clivus and sphenoid, and it's a pretty ugly looking tumor, right? So let's see what ADC can bring to the table here. So we have our axial ADC map. It looks like it's got some areas that are a little bit dark, but in general, it's fairly increased ADC signal intensity, at least compared to the background brain parenchyma. We can quantify that by doing a region of interest, and you can see the mean ADC value is about 1.6 here. So that's relatively high. Now let's look at the answer key and see that in the area that we were doing the ROI evaluation, you can see that the bone is expanded, has a ground glass appearance, and we have a similar appearance of a different bone along the occiput. So this patient has polyostotic fibrous dysplasia, and they had a relatively high ADC value, which predicts that we may be dealing with a benign player here. As I said before, there's quite a bit of variability, though, in the mean ADC. Different scan parameters can alter that, particularly if you're using higher B values that you might encounter with DTI parameters versus DWI. The matrix size can play a role, as can the magnetic field strength. Additionally, different manufacturers and different models of scanners, even within a single manufacturer, can produce a fair amount of variability in the quantitative mean ADC measurements. And so for that reason, a lot of folks have started using a normalized ADC ratio. And the one that I like to use is to compare the mean ADC value of the lesion to that of the medulla. And I picked the medulla simply because it's present on almost all head and neck studies, and it's less prone to having underlying disease processes like chronic microvascular changes than something like, for instance, the pons or the white matter. And so you get that ADC ratio simply by dividing the mean ADC of the lesion by that of the medulla. So in this case, you draw a freehand region of interest of the lesion, you draw a freehand region of interest of the medulla, you divide that of the lesion by that of the medulla, and you get a mean ADC ratio, in this case, of about 0.6. So this is something that Rick Wiggins and I looked at several years ago. We looked at 65 patients with 111 lesions, including both benign and malignant lesions. And we did cut point analysis to figure out what would be the optimal thresholds comparing DWI versus DTI parameters for both mean ADC as well as ADC ratios. And as you can see, just comparing the ROC curves, very similar across the board. But what we found was, for whether it was for DWI or DTI parameters, a cut point of around 1 seemed to hold true as the best cut point. And you can see a reasonable sensitivity and specificity for both, as well as a reasonable area under the curve. So when you look at that ADC ratio, if the lesion to medulla ADC ratio is 1 or less, it's more likely to be a malignant lesion. Obviously, you don't want to interpret that without looking at the other images, because there are certain pitfalls with false positives and false negatives. So you really have to use this just as one particular marker along with all of the other pulse sequences to come together and paint the picture of whether or not you think this is a benign lesion or a malignant lesion. So there are, as I said, some false negatives and false positives. Important false negatives to know about would be that of low cellularity malignancy, and really the classic cases of that would be Chondrosarcoma and Chordoma, which tend to have relatively high mean ADC values, as well as areas of cystic or necrotic change within the malignancy. In terms of false positives, things to keep in mind would be high cellularity benign processes, benign tumors, such as meningiomas, which can obviously be very cellular, and same with Wharton tumors. They're not always cystic, sometimes they're very cellular, and those can also have relatively low ADC values. And then there are other non-neoplastic lesions like abscess and cholesteatoma that can also have reduced diffusivity, so just be aware of that. So here's an example. Is this a benign or a malignant lesion? Well, we have a right petroclival mass. It demonstrates heterogeneous post-contrast enhancement. We look at our T2 weighted imaging. Wow, that's really, really T2 bright. But again, it was enhancing. In this location, something we'd want to think about would be a chondrosarcoma. What does ADC map tell us? Well, this is really, really bright on the ADC. The ADC ratio in this case was 2.17, but this was a chondrosarcoma. So just driving the point home, there are some exceptions to the rule that say that if it's dark on ADC, it's malignant. And a couple of the ones to really burn into your mind would be chondrosarcoma and chordoma. Those can oftentimes have brighter ADC signal than the background brain parenchyma. All right, the next topic is cholesteatoma imaging. So cholesteatomas are non-neoplastic but locally aggressive mass-like accumulations of epithelium. You can think of it sort of as like a skin in the wrong location. On routine pulse sequences, they tend to be T1 iso to hypointense, T2 hyperintense, and non-enhancing. Now, sometimes you'll get a thin rim of enhancement around it. That represents adjacent granulation tissue rather than the cholesteatoma itself enhancing. But importantly, these have reduced diffusivity of water molecules due to the internal keratin contents. So these will be light bulb bright on your diffusion sequences, in particular non-echoplanar diffusion sequences like this coronal haste DWI. So traditional single-shot echoplanar or EPI diffusion has lower sensitivity than the non-EPI diffusion techniques such as haste diffusion. And that's because of the susceptibility artifacts at the air-bone interface at the temporal bones, as well as motion and ghosting artifact, which can make the EPIs a bit limited here. There are some important workarounds to keep in mind that help mitigate these artifacts, as well as to improve the signal-to-noise ratio. And that includes the use of newer EPI diffusion sequences that use either a multi-shot or a segmented EPI prep, such as Resolve. Each of the major manufacturers now has a small field of view DWI prep, and then the non-EPI diffusion sequences like haste can be very helpful in this regard. One of the important things, important roles of diffusion imaging is for the post-op assessment of cholesteatomas. And multiple studies have shown that non-EPI diffusion sequences are superior to EPI diffusion for assessing residual or recurrent cholesteatoma. And if you look at this pooled meta-analysis, you can see just how sensitive and specific these non-EPI diffusion sequences like haste diffusion are for detecting cholesteatomas. Here you see this punctate area of restricted diffusion that corresponds with a small amount of residual or recurrent post-op cholesteatoma. So it's a little controversial, but multiple authors have suggested that these non-echoplanar diffusion preps are sensitive enough that it can obviate the need to do a second look surgery to make sure that the ear and temporal bone are completely cleared of cholesteatoma before doing an ossicular reconstruction. So here's just an example of comparing EPI versus non-EPI diffusion and what it means for cholesteatoma assessment. Here on this coronal temporal bone CT, we see a pacification of the lateral epitympanic recess and blunting of the scutum, sort of thinned out tegmen. Looks really good for a cholesteatoma, right? Well, here's our EPI diffusion, and we're stuck pondering, is this the cholesteatoma? Or maybe it's this dot over here, or maybe it's this little sort of nebulous bright spot. Do our axial haste or non-echoplanar diffusion, and yep, sure enough, it was that little, probably the least suspicious looking area was actually what was cholesteatoma. So hopefully this drives home the point that non-EPI diffusion is a really sensitive tool for detecting cholesteatoma. There are other masses or mass-like things that are bright on your diffusion trace. This can be a particularly helpful thing to add to your search pattern, to always be looking at your diffusion sequence, particularly if you can't give contrast. because these really help to play up the signal-to-noise characteristics and that improved signal-to-noise ratio of diffusion bright lesions that are sort of embedded within that muted background of suppressed fat. Anytime you see something that's bright on your diffusion trace, obviously you want to correlate with your ADC map to see if it's truly got reduced diffusivity like a cellular process, or whether you're dealing with T2 shine through and something intrinsically T2 bright. And there's a lot of these diffusion bright masses. So first of all, we have an epidermoid cyst in this case, T2 bright mass-like lesion in the left cerebellopontine angle. It's exerting mass effect on the adjacent structures. Could this potentially be an arachnoid cyst? Well, the T2 shows a little bit of complex T2 signal intensity, so probably not. But the diffusion sequence really saves the day here and confirms the diagnosis. This is pathognomonic in appearance for a cerebellopontine angle epidermoid cyst. As I said before, meningiomas can be bright on the trace diffusion and dark on the ADC, especially if they're cellular. So here's an example of a very bright meningioma on the diffusion trace. You can see it's dark on the ADC map, and this was confirmed with post-contrast MR imaging. You can see the dural tails of enhancement, very characteristic of a meningioma. Again, meningioma is a benign lesion, but they can be very cellular, and so therefore they can have some degree of reduced diffusivity. Here's an example of a chondrosarcoma. You can see just how much this skull-based chondrosarc pops out whenever it's against that very dark background of suppressed marrow fat that you get from the EPI diffusion prep that has a fat saturation included with it. So it's bright on the trace diffusion. You can see it's also bright on your T2 weighted image, sort of an expansile petroclival mass, and it avidly enhances. Very characteristic of a chondrosarcoma, again, with that improved signal-to-noise ratio that you can see against that background of nulled extracranial fat. Here's a chordoma, again, a diffusion bright mass. You can see that it's intrinsically T2 bright as well, has a little bit of heterogeneous content in terms of its enhancement. But again, you can see that nice increased signal-to-noise ratio when you recognize this on the DWI trace against that dark background. There have been several authors who have looked at using ADC to differentiate chondrosarcoma from chordoma. This comes from Nancy Fishbein's group out at Stanford. And you can see there is some differential mean ADC values between chondrosarcomas, which tend to be brighter on ADC than chordomas, and the poorly differentiated chordomas have even lower ADC signal. Another area that it's important to use diffusion is to look for marrow replacement. And diffusion imaging can be helpful for identifying both infectious and neoplastic marrow replacement. And that's, as I said before, because the EPI diffusion prep requires a fat saturation pulse. And in adults, who for many of us are the majority of who gets imaged, that yellow fatty marrow should get nulled out on the trace diffusion sequence. In this case, you should be aware of that persistent elevation in the diffusion signal intensity in the marrow spaces. So we can see where the yellow arrows are pointing, that elevated diffusion signal within the marrow space. To me, this kind of looks like an Oreo cookie turned on its side, where superficial to it, we see the subcutaneous fat that gets nulled, and deep to it, we see the CSF that's dark. So it sort of gives that Oreo cookie sign of marrow replacement. This is just another patient that had leukemic marrow replacement. You can see both on the diffusion and the T2 sequence that we have abnormal increased signal intensity involving the mandibles, the occipital condyles, and also some telltale and large intraparotid lymph nodes. Diffusion imaging can be very helpful for evaluating and detecting incidental lesions performed on routine brain and spine imaging that are within the head and neck. And that's, again, because a lot of these brain imaging in particular are going to include diffusion as sort of standard practice. And it really offers excellent signal-to-noise between these extracranial lesions and that background of nulled fat and muscle. So here in this case, on this Resolve diffusion trace, we can see a right deep lobe of parotid mass. And really, we can see it nicely because there's fewer distractors surrounding it. We can see on the ADC map that it was very bright. It was bright on T2 as well, and this was an incidental deep lobe of parotid pleomorphic adenoma. Here's another incidental finding. This was on a temporal bone MRI. You can see this crescentic bright diffusion signal intensity along the left carotid artery. We can see it was a little bit bright on FLAIR as well. We recommended a time of flight MR angiogram, and sure enough, we had an incidental dissecting pseudoaneurysm. Last up would be infectious processes. So diffusion imaging can be very highly sensitive and specific for different infectious processes, like abscess that we all know have reduced diffusivity internally within that loculated pus. But you can also use it to identify areas of surrounding cellulitis and phlegmon. They may have diffusion signal abnormality, just not that classic characteristic dark ADC signal from the loculation of pus. And then sometimes you'll even see septic thrombophlebitis due to the presence of a diffusion bright clot. In fact, it doesn't even have to be infected clot. Sometimes you just see it due to the age of the blood products within the thrombus itself. So here's an example of an epidural and a subgaleal abscess with matched bright diffusion trace and dark ADC signal associated with rim enhancement, very characteristic of abscesses. But notice also with the red arrows where we see that bright ADC signal and a little bit of smudgy enhancement corresponding with the surrounding inflammation, the cellulitis and phlegmon. And then last case, I have a case of an IV drug user who presented with septic thrombophlebitis. You can see how complementary the post-contrast T1 imaging and the diffusion sequences are, identifying areas of non-enhancement with matched bright diffusion signal within clot within the cavernous sinus, cortical vein. Here we can see the superior ophthalmic vein is thrombosed, and then all of these superficial scalp veins as well. So in summary, diffusion imaging provides many important insights into head and neck pathologies. There are several diffusion applications such as diffusion kurtosis imaging and IVIM that are still, I think, a work in progress. But overall, diffusion imaging is an extraordinarily valuable adjunct to your conventional MR pulse sequences. I would exert one word of caution, and that's to not bet the farm counting on these absolute quote-unquote malignant thresholds that have been reported in the literature. Just know that there is variability in mean ADCs if you do it on a quantitative basis, and just know that there are some limitations, and you have to look at all of the other pulse sequences and take it all together as one big picture to help determine whether or not you're dealing with a malignant mass or a benign lesion. With that, I thank you for your attention and enjoy the rest of this virtual conference.
Our next lecture will be given by Dr. Cynthia Wu, Assistant Professor, Department of Radiology and Imaging Services, Neuroradiology Division, Emory University School of Medicine. Her topic for today is fat suppression, technical pitfalls and improvement opportunities.
Good morning. My name is Cynthia Wu, and I want to thank Dr. Schmalfus and the program committee for inviting me to speak about fat suppression this morning. Thank you for attending. I have no conflicts of interest to declare. So we're going to talk about fat suppression techniques for the next 20 to 25 minutes because they are important in head and neck imaging. Whether it's looking at edema or an enhancing pathology, we want to be able to separate them out from the surrounding fat, say in the bone marrow or in the subcutaneous soft tissues, which generally would be hyper-intense on T1 and T2 weighted imaging without fat suppression. Of course, when we're dealing with a pre-contrast T1 weighted image, in general, we do not want to fat suppress those because we want to use the T1 hyperintense fat as an internal contrast material against pathology, which usually are T1 hypointense. We're going to go over a few frequently used fat suppression techniques. They include Chess and Dixon, which are based in the idea of chemical shift between fat and water, as well as stir, spur, and spare, which all, at least in part, take into account the intrinsically short T1 times of fat. The goals here today are to discuss some of the basic physics behind each of the main fat suppression techniques. Now, this is going to be a simplified and brief overview, just enough so we can understand why the different techniques have different strengths and weaknesses when we apply them to a clinical setting. And that clinical setting, of course, is going to be imaging of the head and neck. As you may know, it can be hard to achieve uniform fat suppression in the head and neck, so we're going to go into a little bit of the why behind that. Finally, we're going to go over things you might consider in trying to select the best fat suppression technique in the head and neck, and also areas for improvement. So before we launch into the sequences themselves, I want to give us all a quick reminder of how we generate MR signal. If you put protons, water protons, into the magnetic field of the scanner, which here is indicated by the green arrow B0, the spins of the protons will line up essentially parallel or anti-parallel to that magnetic field, and they precess around that axis with their intrinsic spins. Now, when you apply a excitation pulse, indicated here by B1, it can be at any flip angle, but here I am showing 90 degrees just for simplicity's sake. You're going to knock those spins essentially into the XY plane that's perpendicular to the B0 field. The spins will also now precess in phase with each other, and what that does is it generates a transverse magnetization and loses the longitudinal magnetization that we saw on the previous picture. This is actually the signal that we can then detect. If you give it some time, the spins will start to lose coherence as they spin in that XY plane, and that causes loss of the transverse magnetization. This is due to spin-spin interactions between the water protons, and this is the loss of that signal. That time is characterized by the T2 relaxation time. On a slightly longer time frame, the protons will also regain longitudinal magnetization. And this is through energy exchanges between the spin and the lattice or the matrix that is all around these protons. And this is characterized by T1 relaxation time. So there are some fundamental differences between water and fat. Fat has inherently shorter T1 than water. This means they are more efficient at spin lattice exchanges and faster at recovering that longitudinal magnetization. There is also a chemical shift phenomenon between fat and water, and this essentially means that fat and water has inherently different precession frequencies. And this is because of the Larmor equation, which is this omega equals gamma times B naught, right? Where omega is the angular precession frequency of the protons. Gamma is the constant that is unique to each material, and B0, of course, is the local magnetic field. And this basically says that if you have a stronger local magnetic field, a stronger B0, you're going to have a faster precession frequency. Because water protons are right next to very electronegative oxygen, they are basically de-shielded as a result and experiences a stronger local B0 than fat, which are in these long chain molecules. So this results in a chemical shift between water and fat when you look at their precession frequency. And that size of the shift shown here on this graph is going to be dependent on the size of the overall magnetic field. So you're going to have a wider shift if you're going to be at 3T as opposed to 1.5T. However, it is also important to mention that that change in frequency, that size of the shift, is actually fairly small compared to the strength of B naught. So this is going to be a fairly small difference between water and fat, but just enough so that we can use this phenomenon to perform fat suppression. So we can apply a narrow band, RF pulse band, at exactly the fat resonance frequency, which at 1.5 Tesla is about 220 Hertz. And what that does is it flips the fat protons, as indicated here by the fatter yellow arrow, into the transverse plane. And then we will apply a spoiler gradient to dephase that fat signal. So now only the water protons are left in the longitudinal plane, as shown in that blue arrow, right? So then when we apply the excitation RF pulse, only the water protons are excited into that XY plane, and only the water protons are now detectable by the pulse sequence. CISS or chemical shift selective fat-sat techniques require higher field strength. And this is because we just talked about the fact that the separation between these water and fat resonance frequencies are larger at 3T than it is at 1.5T. In fact, at fields lower than 1.5T, these peaks get closer and closer together, so that the RF pulse you apply to try to select out the fat protons are also going to start affecting water protons as well. And this is why at field strength less than 1.5T, CISS should not be used, because you're not going to get good fat suppression. Furthermore, CISS requires local B0 and B1 homogeneity. This is because we are essentially trying to predict the chemical shift of fat here with that initial RF pulse. If you have local field inhomogeneities, as shown here by the area around this mandibular fixation plate, that selective fat suppression RF pulse may not suppress out just fat, Instead, it may fail at suppressing out the surrounding fat, but try to then suppress other materials. Now we're going to switch gears and talk about in-phase and out-of-phase water fat imaging as a way to prepare us for our discussion of Dixon imaging. So again, at 1.5 Tesla, that fat water frequency shift is 220 hertz. So here I have water represented by that light green over here, and fat represented by this purple. So at 4.5 milliseconds, they're going to be together and they're going to be additive to each other in phase, whereas at 2.25 milliseconds, they're going to be exact opposite of each other, so they're out of phase. So depending on when you sample, if you sample over here, the signal between fat and water will be additive or in phase, versus here, where the signal of fat and water are going to be subtractive or out of phase. And this is how we generate our Dixon imaging. So what we do is we acquire in-phase and out-of-phase images for from at least two different TEs, right? And because the in-phase image represents water plus fat signal, and the out-of-phase image represents water minus fat signal, we can then just do a little bit of algebra to derive pure water and pure fat images from those two in-phase and out-of-phase images. Now, you can do additional time points, and this is known as multi-point Dixon or three-point Dixon techniques. You can generate images that has better field heterogeneity tolerance. What's good about Dixon is that it is inherently less sensitive to B0 and B1 inhomogeneities than CISS FAT-SAT techniques. So this is a comparison between a T2 FAT-SAT image on the left and a T2 Dixon pure water image on the right of the same patient. And as you can see, at the level of the upper neck, because there are these anatomic variations between the chin and the rest of the neck, you really lose fat suppression in this perimandibular region around the chin. And whereas on the Dixon technique, you have fairly good uniform fat suppression, and these little submandibular lymph nodes can stand out much better. Although Dixon is more robust than CISS when dealing with field inhomogeneities, it is not completely resistant. And what you will see are these fat-water swap artifacts, where due to the field inhomogeneities, the water and fat signals are mapped onto the wrong image. So like in this patient where we have done a post-contrast Dixon sequence, we see that the left nasal mucosa is not enhancing. The nasal septum and the turbinate in the left nasal cavity look dark on this pure water image. In fact, it is not a black turbinate sign. This area is in fact still enhancing. It's just that the signal in the left nair has been completely mapped onto the fat image over here, this pure fat image, right? If we recognize that this is sharply marginated and it does not follow any real anatomic structure, then we can try to look for that signal on the accompanying fat image. Another way to avoid this artifact is to apply good local shimming before you acquire the sequence, thereby making the B0 more uniform across the scanner and the area to be scanned. But this is just a reminder that if you're going to do Dixon, it would be good to send both the pure water and the pure fat images to your PACS so you can problem solve when you run into something like this. Now we're going to switch gears and talk about STIR, which is short TI Inversion Recovery technique. Unlike CISS and Dixon, STIR relies on the intrinsically short T1 relaxation time of fat for it to work. So we again start with the nice water and fat protons in blue and yellow respectively spinning around that z-axis. And we apply a 180-degree inversion pulse. And this is not a selective pulse, so both water and fat protons are going to be pushed into that negative z direction, right? But because fat and water have different T1 relaxation times, after a short amount of time, when the fat has regained enough longitudinal magnetization to have gotten to that 0 time point, water will still have some longitudinal magnetization. So if we apply the excitation pulse at that point, only the water protons will be excited, and that is the signal we're going to detect. Now, it is important to note here that this is not truly fat selective. Anything that has the same T1 relaxation as fat will also be nulled by STIR. What is the benefit of STIR? Well, it is fairly insensitive to field inhomogeneities. So you can see on this left-hand coronal STIR image, you have very uniform fat suppression in where you have completely lost that fat suppression on a chest T2 weighted fat sat image. Furthermore, because we're relying on the intrinsic T1 relaxation time of fat and not chemical shift, we can use STIR at fairly low field strengths, even below 1.5 T. The drawback of STIR, of course, is that it is not fat specific. So anything that has short T1 will be suppressed. And that includes anything that enhances on post-contrast T1 weighted imaging. So we can only use STIR as essentially a T2 quote-unquote fat suppression technique. And even with that, you can run into some pitfalls. So here you can see a patient that has an expansile right maxillary sinus mass. And parts of that mass is very, very dark on STIR. It looks almost the same as the error in the contralateral maxillary sinus. But is that truly reflective of its T2 signal characteristics? In fact, no. If you look at the T1 pre-contrast imaging here, you'll see that this area in this expanded sinus, which is a mucocele, right, contains this very, very thick proteinaceous content that makes it have a shorter T1 relaxation time. In fact, that T1 relaxation time is so short and so similar to that of fat that it got completely suppressed out on this STIR image. And if you want to see what it actually should look like on a T2 weighted image, here is a chest T2 fat sat image of the same patient in the axial plane. And you see, yeah, it's T2 dark because it's proteinaceous, but it in fact still has some T2 signal, intermediate T2 signal. Another issue with STIR is that it can have longer imaging times because you have to apply that inversion pulse and wait for it to recover to the XY plane. And also it has a higher SAR, energy deposition into tissue as a result as well. And in theory, STIR has lower signal-to-noise ratio because other tissues are also partially nulled as you wait for that fat to, again, lose its longitudinal relaxation. So it becomes a case-by-case basis whether or not this loss of signal-to-noise is going to be important and it's going to impact your image quality to the point that it becomes hard to interpret, right? For example, in this patient with a T2 hyperintense orbital venous malformation, you see that it's pushing the left optic nerve over, right? And I want to be able to say what the signal in the nerve itself is. And perhaps because of the lower signal to noise on the STIR, it's harder to read that than it is on this T2 fat sat chest image, even though you can see that STIR had much better fat suppression around the maxillary sinuses than on this T2 fat sat image over here. Moving on to SPUR or SPARE, and another name used for it is special. So this is a hybrid technique that combines both the chemical shift phenomenon and the inversion recovery technique to try to achieve true fat suppression. So what happens is you apply a fat-selective inversion pulse that's larger than 90 degrees, often it's larger than 100 degrees, and what that does is it selectively knocks the fat protons beyond the XY plane. And then you give it the time to relax until it reaches the XY plane, and you apply a spoiler gradient, essentially dephasing the fat. And after that point, you can excite the water molecules by applying the excitation pulse for your particular sequence. So for Philips and GE, these sequences are named SPUR or special. And the initial inversion pulse for the fat selective inversion pulse will be between 100 degrees and 180 degrees, whereas for Siemens, Camden, and Hitachi, they tend to use SPARE, which is slightly different because it applies a 180-degree adiabatic pulse, so it completely knocks the fat protons into the negative Z direction. And adiabatic means that it will have less B1 inhomogeneity, better targeting that fat, achieving better fat suppression. Although the drawback for SPARE over SPUR is that you end up with a longer time penalty as you wait for those fat protons to recover to that Z equals 0 plane. So these techniques, while they have less B1 inhomogeneity, it's still sensitive to B0 inhomogeneity. But unlike STIR, you can combine SPUR and SPARE with a lot of other different sequences, both T1 and T2 weighted, to kind of use it as an initial fat suppression technique. So let's talk a little bit more specifically about the challenges for fat suppression in the head and neck. As you know, we are going to encounter major local magnetic field inhomogeneity in the head and neck because we have numerous tissue interfaces such as soft tissue, bone, and air interfaces in the region of the sinuses. And you might also encounter field inhomogeneity due to dental hardware or surgical hardware in the face. And furthermore, because you're imaging anatomy of different calibers between your head and the neck, and then the neck and the shoulders, those anatomic variations will all cause magnetic field inhomogeneities. Furthermore, you're looking at, in general, small structures that require high signal-to-noise ratios and good high spatial resolution. So to try to address some of those challenges, we should choose techniques that are less sensitive to B0 and B1 inhomogeneities. So you may want to consider Dixon and stir over CISS. And also you want to optimize shimming. Regardless of which technique you use, you want to try to reduce that field inhomogeneity before you start the scan. And the way you do that is by doing good local shimming, both through the software of the scanner, and also you can consider things like saline bags to reduce that anatomic variation between your neck and your shoulder, for example. And to address the fact that you have smaller structures, you want to maximize your signal to noise. So perhaps you want to consider Dixon T2 techniques over stir. When you do use stir, you want to really maximize the signal to noise by changing other variables such as TE or imaging resolution. So here are some examples of those challenges that we may face. On the left, you have a T2 FATSAT image using that CISS technique. On the right, you have a Dixon water image. So on the left, you can see that we lose a lot of signal because of local field inhomogeneities and susceptibility in the region of the maxillary sinuses. Whereas on the right, you can see the retroantral fat, for example, much better on this Dixon technique. We already know that metal can be very challenging. So this is a T2 FATSAT image where we have lost the suppression around this implant. But the same patient, when scanned with stir technique, has much better, much more uniform fat suppression in that area around this mandibular fixation plate. When we're looking at the upper neck, where the chin meets the neck, again, you can lose all the fat suppression. This is actually meant to be a T2 FATSAT image, and you can see all the fat in the subcutaneous soft tissues. Whereas if you use Dixon on the same patient and look at the pure water image, you have very uniform fat suppression, and the submandibular glands stand out much better against the surrounding fat. In the lower neck, similar story. Here is a T2 FATSAT image where you have lost fat suppression around the head of the clavicles. You have lost fat suppression near the long apices because of the air soft tissue interface, and also in the supraclavicular fossa. You can barely see the inferior edge of the thyroid over here. On a Dixon image of the same patient, you have, again, uniform fat suppression in all of those areas that previously had been problematic on the T2 FATSAT image. You can actually outline the inferior margin of the thyroid over here, and then you can see this little lymph node standing out against the surrounding fat and the surrounding vasculature on this Dixon image. Same idea, but illustrated on a coronal post-contrast image. This, again, is the CISS technique, where you have basically lost a lot of signal in the lower neck over here, and you have maintained that signal when you use a Dixon technique. Even with a little bit of motion artifact, you can see that this area looks fairly well depicted. So this has actually been shown in a 2018 article in AJNR. Dr. Gadikeri demonstrated that the Dixon technique had better signal to noise, had better fat suppression and image quality, and actually took a shorter amount of time than the stir and the spur. So this showed that in the head and neck, you may want to really seriously consider Dixon as the imaging technique of choice. However, as we had hinted at earlier, Dixon is not perfect. There is still some sensitivity to field inhomogeneities, and you can end up with this fat-water swap artifact, right? You can clearly tell this is an artifact because it has those sharp, clearly marginated edges, right? But if I didn't have the fat image, it's essentially impossible to interpret this water-only image. Whereas if you look at the same patient on the T2 FATSAT chest image, you can clearly see all the floor-of-mouth structures. So how do you want to solve this fat-water swap problem? With multi-point Dixon, when you use more than two in-phase and out-of-phase images, these additional acquisitions can help reduce the effect of that magnetic field inhomogeneities and help you avoid this fat-water swap artifact. but it does not completely take care of it. So there are, in fact, multiple proposed post-processing techniques that are being researched on to try to address this after you have acquired those in-phase and out-of-phase images. They include region-growing techniques from areas of higher confidence. So if you know one voxel is fat, you can then try to use all these fancy computational techniques to determine if the voxels around it should also be fat, and vice versa. And another technique that people are looking into is to try to use training algorithms that has accurate mappings of fat and water, and using that to kind of teach the computer and algorithm to tease out a predicted fat and water map from the in-phase and out-of-phase images, and then compare them to the actually generated image to identify areas that may have been mismapped. So in summary, we went over 4 of the major fat suppression techniques, CHESS, Dixon, STIR, and SPUR. We went over the basic physics behind each of them. For CHESS fat set technique, it generally is considered a slightly faster technique, but you can't perform it at low magnetic field strengths, and it's very sensitive to field variations. So you need to perform really good shimming to get it to work well. Dixon techniques are relatively less sensitive to field variations, but it tends to be a little bit slower, and then it can generate this fat-water swap artifact. So you want to be able to recognize that and hopefully have your technologist send you both the pure water and the pure fat images for Dixon so that you can problem solve if you do run into this artifact. For STIR imaging, it is very nice in terms of being insensitive to field inhomogeneities. So consider STIR in times when you have to image patients with a lot of metal or a lot of dental artifact. But it is also considered slower, and you can't use it for post-contrast T1 weighted imaging. STIR also has slightly lower signal-to-noise compared to the other techniques in theory, so you would want to try to really optimize that sequence if you do use it. And finally, for SPUR and SPARE, these are hybrid techniques that are of intermediate sensitivity to field variation and of intermediate speed, and you also can't perform them at lower magnetic fields because they do partly rely on that chemical shift phenomenon. Specifically for head and neck, we want to optimize local shimming. We may want to consider Dixon over CHESS and just try it out to see how it looks on your scanners, especially because it tends to offer more uniform fat suppression in this very challenging area. And consider STIR for patients with a lot of metal implants or areas of high susceptibility where you can't get good image quality, say, from Dixon or CHESS. Thank you so much for your attention. I want to thank my head and neck colleagues, Dr. Aiken and Dr. Banyan, for their support. And I also want to thank Dr. Puneet Sharma, who's our medical physicist, who has provided a lot of valuable input for this talk.
Our next lecture will be given by Dr. Ari Blitz, Division Chief, Neuroradiology, University Hospitals, Clinical Professor, Radiology, Case Western Reserve University School of Medicine. His topic for today is post-contrast volumetric T2 imaging. Why is it superior?
Hi, my name is Ari Blitz from University Hospitals Case Western Reserve University School of Medicine in Cleveland, Ohio. And today I'll be talking to you about post-contrast volumetric 3D CISS imaging. CISS imaging is actually different from T2 weighted imaging, and why it's superior, why it can be helpful to us in clinical practice. I do have a few disclosures. So by the end of this lecture, I'd like you to be able to describe the distinction between CISS imaging and standard T2 weighted imaging. I'd like you to be able to list at least 3 advantages of using CISS or similar techniques after contrast, and also to begin to think about how to incorporate this technique into your clinical practice. First, we'll talk about the technique itself, and then we'll go through several cases illustrating different advantages of this approach, including the fact that we can acquire higher spatial resolution imaging with 3D techniques in a clinically acceptable time period. We can see relatively small anatomic details, and we can assess the anatomic relationships between different structures and boundaries between different areas of anatomy with great precision. We can visualize anatomy in continuity with a 3D volume, which is to say that we can follow a cranial nerve, for instance, from its point of apparent origin, often to its destination or near its destination, We can identify really quite small areas of contrast enhancement, and we can verify that that contrast enhancement is in fact within the structure of interest rather than being an adjoining vessel, for instance. We can use this technique to extend the anatomic area that we have been able to assess in the past and find areas of abnormality outside of the range of the regions that were previously well visualized. And we can look with this technique, and this is critical particularly for operative planning, we can look at the relationship between the cranial nerves and masses or vessels, and we can distinguish between abnormalities within or outside the structure. And of course, this aids us in clarifying the anatomic structure of origin of a mass, and for that reason, the differential diagnosis. So to begin with, let me mention that CISS imaging, although it appears to be a T2-weighted technique, is a steady-state free precession technique, which is very highly SNR efficient. And for that reason, it allows for a relatively rapid acquisition in a clinically reasonable time period with high spatial resolution and excellent signal-to-noise. It's called CISS imaging on Siemens magnets, Fiesta C on GE magnets, and balanced fast field echo as examples. Balanced fast field echo on Philips magnets. It's typically thought of as being T2 weighted, but in fact, it has a mix of T2 and T1 weighting. And this is of critical importance to us because it allows us not just to assess structures at very high spatial resolution, but we can also use it to look for post-contrast enhancement. We do acquire all of the protocols that I'll talk about today in 3D, so we can reconstruct them post hoc into any arbitrary plane. And the CISS imaging is a component of a larger protocol that includes vibe imaging for T1 and stir space imaging for T2 weighted appearance. Notice that this asterisk here in the center is on a mass that's a chordoma. Look at how bright that is on stir space. It's different in appearance on CISS imaging. CISS imaging, again, does not give you a classic T2 appearance, but it's useful for other reasons, as we'll talk about today. After contrast, we do vibe imaging with fat saturation, and we repeat the CISS imaging. And the CISS imaging is, again, not a typical T1 or T2 weighted technique, but really the heart of the sequence because it allows us to make really fine anatomic assessments. The spatial resolution that we use for CISS imaging in the skull-base protocol, which is an example of a high-resolution protocol that I've shown here on the screen, is 0.6 of a millimeter isotropic. So we use our highest spatial resolution for the CISS imaging, and we can acquire this high-resolution protocol with the attendant sequences in about 25 minutes. So that will fit into most imaging schedules and yet provide a really very high level of imaging data. This is a case of post-contrast, a case with post-contrast CISS imaging. Here we're in the coronal plane through the nasal cavity and paranasal sinuses, and on the right-hand side in the sagittal plane. And you can see there's a mass here. This mass was actually dark on pre-contrast imaging. It's enhancing on CISS imaging, so it is in fact brighter than it would have been had I shown you the pre-contrast images. You can see here on the right-hand side, that's the olfactory bulb overlying the cribriform plate. And on the left-hand side, the olfactory bulb is somewhat elevated. There's a small nodule there, about 1 millimeter in size, that is elevating the olfactory bulb on the left-hand side. At surgery, this was proven to be esthesioneuroblastoma, which had extended through the cribriform plate. And it's an example of how we can see relatively small anatomic details with this sort of high-resolution imaging approach. Here's a patient on post-contrast CISS imaging in the coronal plane, a patient with recurrent Cushing's disease, and we're tasked, of course, with trying to figure out where the tumor is in this patient. We can see the mass here to the left of midline, and I want you to notice that this mass extends below the level of the floor of the sella turcica. That's a critical detail. It only extends by a few millimeters, but here's the patient at the time of surgery with a typical surgical exposure. And the surgeon, knowing that the mass extended below the floor of the sella turcica, was able to extend the exposure in this case. And here is the mass lesion that we saw in pre-contrast pre-operative high-resolution imaging. And they were able to get the entire mass out, and the patient went into remission. So this is another example of how we can visualize relatively small defects, relatively small details with this high-resolution technique. In this case, this is a patient with a skull-base chordoma, and what I want you to notice here is the way in which we can see the mass extending through the outer cortex, the outer table of the skull, and passing through the bone in its entirety, breaking through the inner table of the skull here, extending into the interdural space. We can see on post-contrast CISS imaging the distinction between the inner table of the skull, and this is the inner layer of the dura. Of course, we know there's also an outer layer, a periosteal layer of the dura, applied tightly to the inner layer of the skull. Here, the tumor is between those two layers, and we can see it at the arrowhead breaking through that inner layer of the dura into the subarachnoid space. And here it is adjacent to the vertebral artery. So this is an example of how this technique can be used to assess the detailed anatomic relationship of masses to boundaries in this example in the region of the skull base, but it can be used in an analogous fashion in other regions as well. This is the next case. Here's a patient where we can see in sagittal plane on the left-hand side, axial plane on the right-hand side. Here's the pons and the medulla. You can see the abducens nerve extending through the subarachnoid space. That's a normal abducens nerve. We cannot see it further than the subarachnoid space on this pre-contrast CISS imaging. Here it is in the axial plane. But once we give contrast, now you can see the abducens nerve from the cisternal segment here, short dural cave into the interdural segment as it overlies the dorsum of the clivus. Here it is getting into the cavernous sinus. It would pass under Gruber's ligament to go into the cavernous sinus. And at the arrowhead, you can see it passing through the superior orbital fissure. And this is, for that reason, an example of how we can see the anatomy really in continuity in a way that we can't as well with other imaging approaches. So we're trying to see sometimes very small structures in 3D imaging in continuity, and that helps us establish that the anatomy is that the structures that are enhancing or pathologic are in fact what we think they are, because we can trace them in continuity through multiple different slices. In this case, you can see in the sagittal plane on pre-contrast CISS imaging, you can see the midbrain. Here's the pons, and this is the third nerve, the oculomotor nerve, extending anteriorly towards the base of the skull. And you can see that the cranial nerve is fanned out in its distal cisternal segment from about 1.5 millimeters to about 2.5 millimeters. This is, again, an example of how we can see small details on high-resolution imaging, including cysts that we couldn't necessarily see with standard imaging. And here on the post-contrast images, you can see that that distal cisternal segment is, in fact, pathologically enhancing. Look at how much brighter that is compared to the pre-contrast image. That's an example of what enhancement looks like on CISS imaging. And in fact, this is a very small area of enhancement. And we can see this on the post-contrast CISS image and verify that it is in fact within the oculomotor nerve, because we can see the cranial nerves in continuity as an example on post-contrast CISS images. Here we have just a fusion with an MRA showing an aneurysm that is coming down from above to compress the oculomotor nerve on the left side. This is a case of a compressive oculomotor nerve palsy. In this case, again on post-contrast CISS imaging, we can see the abducens nerve here in the axial plane passing into the cavernous sinus on the left-hand side. This patient presented actually with a right-sided abducens palsy. Standard imaging was normal. We can't see the abducens nerve on the right-hand side. Here's a sagittal reconstruction through the right-hand side. You can see the cisternal segment of the nerve coming up. It enters the interdural space here, but at the arrowhead, it's no longer well seen distally, and that's because it's pathologically enhancing. This was felt to be a case of Tolosa-Hunt syndrome, and illustrates how we can see anatomy in regions that were previously not well visualized, and we can make diagnoses or at least identify where pathology is in areas that we couldn't previously see well. In this image, this is a coronal CISS image before contrast in a patient presenting with facial pain. You can see that the left trigeminal nerve now is normal. It's nice and rounded as it should be. On the right-hand side, we see this triangular structure, which is really too thick. The patient had right-sided facial pain. And after we give contrast, we can now see that, in fact, this triangular structure is not only the trigeminal nerve on the right-hand side, it is, in fact, the compressed trigeminal nerve in the central aspect here, compressed by a vein below and an artery above. And so we can use this technique to assess the extent of compression of cranial nerves when there is contact with adjoining blood vessels, and see the deformity of the nerve much better when we compare pre and post-contrast CISS images. And this is something that we've published on in the past. Notice how the left trigeminal nerve, by the way, has not changed in its appearance between pre and post-contrast CISS imaging. The cranial nerves, with the exception of the region of the ganglia, do not enhance typically. So we can use this technique to visualize the relationship of the cranial nerves to blood vessels. Here's a case where there is a suprasellar mass lesion. This is in fact a meningioma. And the question from the surgeon is going to be, where are the cranial nerves in relationship to the mass that they are going to operate upon, or from the radiation oncologist, the mass that they're going to irradiate. And I would say, and I hope you can appreciate how on the post-contrast T1 weighted image, the optic nerves are really not easily appreciated here. This is a post-contrast coronal T1 weighted image. But once we give contrast on the post-contrast CISS sequence, we can see that the optic nerves are very well seen. And you can see the extent of deformity of the right prechiasmatic optic nerve here, and also the displacement of the left prechiasmatic optic nerve in a way which is much easier to appreciate than on standard post-contrast T1 weighted imaging. So again, we can use this technique to assess the relationship of masses to cranial nerves or other vital structures. In this case, the patient, this is a patient who presented from an outside hospital, and they were losing vision on the right side and had been for several months, and the diagnosis which they carried was one of optic neuritis. The patient had right-sided visual loss, and as I'm sure you can appreciate, there's pathologic enhancement here getting into the region of the optic canal. And this was interpreted as a case of optic neuritis. As I said, on the outside institution study, we repeated the imaging using a high-resolution technique, and you can now appreciate in the axial plane that we have here some pathologic enhancement, and in fact there are dural tails along the anterior and posterior aspect of that mass in the optic canal. And in the axial plane on post-contrast CISS images, I hope you can appreciate that this is in fact the optic nerve. And this mass does not involve the optic nerve. This is not a pathologic enhancement of the optic nerve as we would see in optic neuritis. It's not a mass arising from the optic nerve, but rather a mass displacing the optic nerve laterally, so in this direction. And this is a case to allow us to see the way in which this technique can be used to distinguish between intrinsic and extrinsic abnormalities of anatomic structures, including the cranial nerves, and also to the related advantage is that you can clarify for that reason the anatomic structure of origin of the mass. So here is an intraoperative review from my colleague at my former institution at Johns Hopkins, Dr. Gary Gallia from neurosurgery, and you can see that here he's taking a mass from a medial approach, from an endoscopic approach off of that optic nerve, or rather from the region of that optic nerve, and this was proved to be a meningioma. Here's the optic nerve in the foraminal segment after the mass had been removed, and the patient's vision stabilized and I believe even improved slightly after this surgery. In a similar sense, we can apply the same approach in other areas to assess the region of origin of masses or its relationship to other structures. And here are a few examples with the extraforaminal facial nerve, the component of the facial nerve that passes out of the stylomastoid foramen. Here's a sagittal image. Here's the facial nerve passing out of the stylomastoid foramen and going through the parotid gland. Here, P is for parotid. In fact, we can see it branching in the parotid gland. In the axial plane, you can see the arrowhead is on the retromandibular vein, and here's the facial nerve that are just lateral to the retromandibular vein. So this is a normal case of a facial nerve. And I'll now show you several pathologic cases to give a sense of how this can be useful in terms of diagnosis and differential diagnosis. Here's a case, the same orientation in the sagittal plane, anterior to the left of the screen, posterior to the right of the screen, on post-contrast CISS imaging, where you can see a mass extending from the stylomastoid foramen. And here's the seventh nerve, and it's extending from the inferior pole of that mass. Now, this mass we might therefore expect to be arising from the cranial nerve itself. And in fact, this proved to be a facial nerve schwannoma. In this case, the same anatomy and the same orientation, we have again the facial nerve extending from the stylomastoid foramen. And here's a mass lesion, and the facial nerve is draped over that lesion rather than arising from the distal pole of that lesion. And in this case, the patient had a pleomorphic adenoma. So, of course, a mass arising from the parotid gland and displacing the facial nerve rather than arising from or directly involving the facial nerve itself. In this case, which is the last case, you can see the facial nerve again extending from the stylomastoid foramen. But then, just distal to the stylomastoid foramen on this post-contrast CISS image, we lose it. Where did it go? And just like in the case that I showed you that was suspected to be Tolosa-Hunt syndrome, the reason we don't see the facial nerve well past that distal arrow is it's pathologically enhancing. The cranial nerve itself is pathologically enhancing. And so this is a case where there is enhancement of the nerve itself diffusely, and it proved to be a case of perineural spread of basal cell carcinoma. So again, these cases are here partly to illustrate how we can use this high resolution technique to distinguish between abnormalities arising within an anatomic structure or adjacent to it, and that may help us, of course, in differential diagnosis. So in summary, high resolution 3D imaging, including CISS imaging before and after contrast, and it's important to be able to compare the two sequences to assess when there is in fact enhancement, can be acquired in a clinically acceptable time period. It allows us to see really relatively small abnormalities which are clinically relevant, and to assess the relationship between masses and anatomic structures and boundaries of the anatomy that we're assessing. We can see anatomy in continuity on 3D imaging. We can follow small structures, including the cranial nerves, in continuity, and that can be very helpful for clarifying the abnormalities that we're trying to assess. And we can see relatively small areas of enhancement below the spatial resolution of what we would typically see, and we can verify that those areas of enhancement are in fact within the structure in question rather than being from another structure joining it, for instance, a prominent vein. We can assess anatomic regions which were previously not well visualized with this technique, and we can assess the relationship of masses, of cranial nerves to masses or blood vessels, and distinguish between intrinsic and extrinsic abnormalities, as well as clarify the anatomic origin of a mass, aiding in differential diagnosis. Here are some sources for further reading. And I'd like to acknowledge my collaborators in this work, and there are many, and all of the people listed on this page, certainly, and many others have been really critical. But I'd like to highlight in particular my friend and colleague, Dr. Nafi Aygun from Neuroradiology at Johns Hopkins, and my friend and colleague from Neurosurgery at Johns Hopkins in skull-based surgery, Dr. Gary Gallia, both of whom have been wonderful friends and collaborators and colleagues for many years. With that, I'd like to thank Dr. Schmalfuss for the invitation, and all of you for your kind attention. And thank you. I hope once this pandemic is over, we'll all get a chance to meet in person, and I'll look forward to that. And thank you.
Our next lecture will be given by Dr. Nancy Fishbein, Professor, Diagnostic Radiology, and by courtesy, Otolaryngology, Head and Neck Surgery, Neurology, and Neurological Sciences, Neurosurgery, and Radiation Oncology, Stanford University School of Medicine. Her topic for today is Arterial Spin Labeling, Advantages and Disadvantages.
Hello, my name is Nancy Fishbein from Stanford Neuroradiology, and I'll be speaking to you today about arterial spin-labeled perfusion MRI in the head and neck, advantages and disadvantages. I have no disclosures. I'd like to thank Dr. Schmalfuss and the program committee for the invitation to speak today, ESI for organizing our meeting, and all of you for being here today. I'd also like to thank my friend and colleague, Dr. Greg Zaharchuk, for implementing clinical ASL at my institution. Today, we'll talk a little bit about the ASL technique, review its advantages and disadvantages, and spend most of our time on case examples. ASL is an MR-based technique that characterizes tissue perfusion. It's non-invasive and no exogenous contrast material is required. Blood-water spins are, quote, tagged in the neck with a magnetic label. These labeled spins reach the brain tissue in about 2 seconds, and a subtraction map yields an image of brain perfusion. The coverage routinely is from the upper neck to the vertex. Therefore, paranasal sinuses, orbits, and skull base are included in a routine whole brain ASL acquisition. Looking at this diagrammatically, you can see the image tagging plane in the neck and the image acquisition plane more superiorly. And here are our labeled spins moving from the tagging plane to the image acquisition plane. In addition to the tag, we have a control. Multiple tag control pairs are averaged and then processed automatically to yield a map of blood flow that looks like this, as shown in this example of cerebral blood flow. If we look at a patient example, we can take this lady, a 73-year-old woman with worsening headache. This is a post-gadolinium Bravo image that shows some asymmetrical fullness in the right cavernous sinus, consistent with a cavernous sinus meningioma, but it might be somewhat easy to walk by that lesion in a patient who simply has headache as compared with diplopia or a specific cranial nerve palsy. When we look at our qualitative ASL image that is just part of the routine scanner output, we see that this lesion is extremely bright, which really draws our eye to the pathology. In addition to a qualitative analysis, we can get quantitative information by dividing this image by the proton density. We can get an actual measure of blood flow if we wish to do this, for example, for a research protocol. In addition to the grayscale quantitative output, we also can get color quantitative output showing the lesion in a color map and comparing the perfusion of the meningioma, for example, to the rest of the brain tissue. So this turned out to be just a grade 1 meningioma. The patient was biopsied and then treated with stereotactic radiosurgery. With regard to the advantages of ASL, we can highlight pathology without gadolinium, pathology that might otherwise be missed. It helps us with our differential diagnosis, which contributes to our tumor boards and our teaching conferences. It helps us to detect persistent or recurrent disease, which is always important in the head and neck. It helps us to follow treatment success or failure after chemotherapy, radiation therapy, or stereotactic radiosurgery of ASL bright lesions. And it contributes to our understanding of pathophysiology, especially if we're looking at quantitative evaluations. With regard to disadvantages, the main disadvantage is low signal to noise, leading to a long acquisition and setting us up for the possibility of patient motion. On our scanners, the ASL sequences take 3.5 to 5 minutes, but we hope in the future that this will be much faster if our ASL scientists, like Dr. Zaharchuk, can use proton density, T2, or quick ASL images to train networks. if he can develop things like synthetic ASL, and if motion correction can be applied to ASL acquisitions. This also suffers from low spatial resolution in order to try to move things along. Our in-plane spatial resolution is on the order of 3 to 4 millimeters, and our through-plane resolution on the order of 4 to 6 millimeters. We also have relatively limited coverage from the upper neck to the vertex. We really can't do ASL in the lower neck. Also, we can't do it in places like, for example, the oral cavity with all of the susceptibility artifacts. And there are many artifacts with regard to ASL, a number of which we will discuss. With regard to some of the artifacts and cautions, we've already mentioned that the long acquisition is a setup for motion. We also have physiological motion, such as CSF flow, that can be troublesome. Motion can mimic pathology, for example, venous reflux in our venous system. We can't add ASL on once gadolinium has been given because we don't get any signal from those images, and I'll show you an example. In addition, ASL is a straight axial image, whereas most of our other brain acquisitions, for example, follow the ACPC line, and therefore the sequences are not perfectly aligned. With modern PACS and the ability to do cross-referencing, this usually is not such a big deal, but there are definitely times when I have wished that ASL was perfectly aligned with other imaging acquisitions. As an example of motion, here we see a patient with a perfectly acceptable axial fast spin echo T2 weighted image. But if we look at the ASL grayscale image or the color scale image, you see all of this swirling. And this is because of the spiral K-space trajectory and the misregistration of signal intensities that occurred when this patient moved during the ASL acquisition. Here's an example of a patient with CSF labeling artifact. What happens is that CSF spins are tagged in the labeling plane and then move into the imaging plane. And this shows up as high signal in the pre- or perimedullary CSF. So here we are at the level of the medulla. We have normal CSF in the premedullary cistern, but on our ASL grayscale and color acquisition, we have abnormal signal representing CSF flow. Here we have an example of venous reflux, where spins are labeled in neck veins at the same time that they are labeled in neck arteries. Those can then reflux into the dural sinuses, as shown here, and this can mimic arteriovenous shunting, something that we will talk about later in the talk. This is an artifact that is also commonly observed on time-of-flight MRA acquisitions, where we have spins that labeled spins that are venous rather than arterial and that reflux in the venous system. This was a patient, however, who happens to be post-op from a right-sided ECIC bypass for Moya Moya. This patient had undergone multiple angios, and there was no dural arteriovenous fistula or other shunting lesion. So this was simply venous reflux, and you can see, for example, that the transverse sigmoid junction looks normal on this axial flare. With regard to post-gadolinium ASL acquisition, here is an axial fast spin echo T2 in a patient who had intravenous hemorrhage. If we look at our ASL acquisition, it looks like a snowstorm in Alaska. And the reason for this, if you look at our PACS list of acquisitions, is the ASL was done after gadolinium had been given for bolus perfusion. Gadolinium-based contrast agents result in severe shortening of blood T1 relaxation time. Our labeled spins quickly decay back to their equilibrium magnetization state before they reach the imaging volume, and this results in absence of signal. So don't be thinking that if you want to add on ASL, you can do it post-GAD, because you can't. Moving on to our case examples of normal or common head and neck findings, areas of high signal on ASL are common in many areas of the head and neck. Don't assume that there's no pathology in these areas. You have to scrutinize your anatomical images. But if everything looks okay, and especially if things are symmetrical, it is likely normal physiological variation. Here's one of the most common findings on ASL, which is the bright nose. This is related to the nasal cycle. You can see a prominent but normal appearing right inferior turbinate, and this shows up as high signal on ASL. We also commonly see high signal related to the choroid, the vascular layer of the eye. You can see that this is normal on the axial T2 weighted image. Very common for us to see high signal related to the auricle. You can see that this patient's ears are normal, but the auricle does have a robust blood supply, and many patients will demonstrate high signal in this area. Also commonly seen is high signal in the facial skin, probably related to vasodilation. Many people get hot within the scanner. You can see on the T2 weighted image that this patient's skin is perfectly normal, but it is very common for patients to show high signal symmetrically in the facial skin on ASL. The pituitary gland is also hypervascular under normal circumstances. Here is a normal looking pituitary gland. You can see that it is very bright on ASL. Lacrimal glands are also commonly hyperintense. In this case, the lacrimal glands are symmetrical and normal appearing. This is a common normal finding. The parotid glands are also commonly high signal on ASL. You always want to look at your anatomical imaging, make sure the patient doesn't have some sort of bilateral parotid pathology, but in this case, the glands are normal, just moderately hyperperfused on ASL. Again, a very common finding. Look at your anatomical images, make sure that things look normal. Let's move on and talk about case examples of pathology. Neoplasms, we can characterize neoplasms as to whether they are hypervascular or not. ASL can help us avoid a miss. ASL can help us follow treatment-related change, and ASL can sensitize us to tumor recurrences. With regard to vascular lesions, especially dural AV fistulas and vascular malformations, ASL is extremely helpful, and it can also be helpful in cases of infection and inflammation. Here is a patient, a 65-year-old with left pulsatile tinnitus, as well as dysphonia. If we look at our axial temporal bone CT image, we see a retromembrane hypotympanic mass that our colleagues, our clinical colleagues, could look in and see a red retrotympanic lesion. This lesion also extends to the jugular foramen. We see this enhancing lesion on our axial postgadolinium fat-suppressed images, and on our ASL image, this lesion is markedly hyperperfusing, and this is a jugular paraganglioma. In this particular case, I also want to point out that the ASL image is not particularly pretty. This is a rare 1.5 Tesla ASL example, probably the only 1.5 Tesla example I'll be showing you, and you can see why, in general, we prefer 3T with its higher signal to noise for ASL. So ASL can be done at 1.5T, but it's much better at 3T. Here's a patient, 68 years old, with progressive left facial numbness, a mass in the pterygopalatine fossa, extending along the Vidian canal, also extending along V2 in the foramen rotundum. A reasonable differential might be perineural spread from a skin cancer or maybe a minor salivary tumor like adenoid cystic. This patient had a history of renal cell carcinoma, but that's not an uncommon history in a 68-year-old male. When we look at our ASL, however, we see that the lesion is markedly hyperperfusing, and that would be somewhat unusual for perineural spread of squamous cell carcinoma or an adenoid cystic. Those can be hyperperfusing on ASL, but not usually a light bulb. This lesion was biopsied, and this was a hypervascular metastasis of renal cell carcinoma to the pterygopalatine fossa. Sometimes things can be very subtle, and ASL really helps us. This is a 46-year-old patient who had undergone prior resection of a right jugular paraganglioma, and this area looked excellent on our ASL. However, you can see that there is an area of marked hyperperfusion in the left jugular foramen that corresponds to a lesion on the post-gadolinium image. This lesion was also present on multiple priors. However, they had been missed because it's rather subtle and kind of blends in with the carotid artery and the jugular vein. So ASL can really help us to pick up subtle hypervascular tumors that we might miss with only our routine imaging. Here's a patient who is 78 years old who underwent an MR for TIA. There is a lesion in the right parotid gland, but it would be very easy to walk by this on a routine MR for TIA. In this particular case, ASL to the rescue. You can see on the ASL that there is a bright lesion in the right parotid gland. Our eye is drawn to this mass lesion, and this turned out to be a mucoepidermoid carcinoma. So much better if we don't miss this lesion. This patient did undergo a subsequent surgical resection of her tumor. Moving on to some cases of post-treatment imaging. Here's a young patient previously operated for a juvenile angiofibroma who now has recurrent symptoms. We look at our post-GAD image, we see this large hypervascular lesion involving nasal cavity, paranasal sinuses, skull base. It is extremely bright prior to gross total resection. When we look at our post-op imaging, we see what looks like an excellent resection, but some of these areas, it's a little hard to be sure if this is post-operative change or residual tumor, and it is highly reassuring to look at our ASL to see that there are no areas of hyperperfusion and to be able to feel confident that indeed this is an excellent gross total resection and this patient can just undergo routine imaging follow-up. Moving on to this patient, this is a 66-year-old with left pulsatile tinnitus, decreased hearing, and a change in voice. We look at our axial post-gadolinium image prior to stereotactic radiosurgery. We have a mass in the jugular foramen with internal flow voids, markedly hyperperfused on ASL, a classic jugular paraganglioma. This patient is subsequently treated with stereotactic radiosurgery. The mass looks a little smaller. The flow voids look a little bit different. But when we look at our ASL, we see that there is a dramatic reduction in tumor perfusion. And it helps us to feel very confident that the patient is having an excellent response to stereotactic radiosurgery, even though the tumor hasn't changed all that much on the post-gadolinium imaging. So ASL can be very helpful in following these patients post-radiosurgical therapy. Here was a young woman, 28 years old, with a sinonasal undifferentiated carcinoma, and she's pregnant. She gets treated with chemotherapy only. Here's our baseline imaging, this large lesion of the sinonasal cavity extending into the orbit, extending into the anterior cranial fossa, invading brain and resulting in brain edema, markedly hyperperfused on ASL. After the first cycle of chemo, things are looking a lot better. The tumor mass is much smaller. She still has a lot of brain edema. The ASL is still abnormal, but she's looking a lot better. Just prior to delivery, she looks dramatically improved on her routine T2 imaging, and on ASL, we no longer see a hyperperfusing mass lesion. So in this particular case, we were able to monitor this patient with T2 and ASL. No radiation, no gadolinium, a functional stand-in. ASL served as a functional stand-in for PET-CT. This patient delivered her child. She was then able to go on to get consolidative chemoradiation and has done extremely well. With regard to vascular lesions, here we have a patient who's experiencing pulsatile tinnitus. 76-year-old man, axial T2 weighted image. I ask you to look and tell me what side is the pulsatile tinnitus. Well, I don't know, just based on the axial T2. It's hard to appreciate any abnormality. This patient also got a CT angiogram. And on the CT angiogram, I might notice that the jugular vein is denser on the right than it is on the left. I might also notice that the the occipital artery appears larger on the right than on the left on a couple of cuts, but that's fairly subtle. However, if I look at my ASL, there's obvious high signal related to the right jugular bulb, and that helps me to say that the pulsatile tinnitus is on the right, and not only that, I think this patient has a right-sided dural arteriovenous fistula. The patient goes on to a catheter angiogram, lateral and AP right ECA injections, and we see evidence of a dural AV fistula that is fed by branches of the ascending pharyngeal and occipital arteries. So why does this happen? Well, ASL signal is not normally seen in cerebral veins and dural venous sinuses because of T1 decay during capillary transit and the exchange of labeled blood-water protons with the extravascular space. When we have a situation of arteriovenous shunting, labeled blood is shunted directly from feeding arteries to draining veins. And this phenomenon has a very high sensitivity and specificity for dural AV fistulas and AV malformations, as was nicely summarized in a paper by Dr. Amakotawa in 2018 in AJNR. Looking at this diagram to represent the same discussion diagrammatically from Dr. Lee from this nice exhibit from the 2018 ECR, here's the situation in normal brain. We have our tagged protons that go through the capillary bed. They experience this decay and exchange, and by the time we get to the venous side, our protons are no longer tagged. When we have a dural AVF or AVM, we shunt these labeled or tagged protons through the nidus of the AVM or the nidus of the AV fistula, and on the venous side, we have tagged protons leading to venous ASL signal. So tremendously helpful for shunting lesions. Here's a patient with a CC fistula. This young man had been previously treated, but now he has recurrent symptoms. We look at our CTA. His left cavernous sinus is abnormal. He's got some sort of balloon device in there. He's got an enlarged superior ophthalmic vein. We see his abnormal cavernous sinus, his enlarged SOV, and his proptosis on the left. On ASL, we see evidence for venous shunting in the cavernous sinus and in the superior ophthalmic vein. He goes on to a catheter angiogram that shows this residual shunting, the draining into the cavernous sinus and the enlarged SOV, and he undergoes additional embolization. Following embolization, he's still proptotic, his cavernous sinus still looks abnormal, and his superior ophthalmic vein is still enlarged. But when we look at our ASL, there's no longer any labeled spins shunting into the cavernous sinus or the superior ophthalmic vein. He goes on to get a follow-up catheter angio. We see his embolization material. We do not see any more shunting. His CC fistula is cured. So ASL is really terrific for helping to diagnose shunting lesions and for helping to follow them after therapy. In our last moments, let's look at an example of a patient with infection and inflammation. This is a young woman with left-sided ear pain and a facial droop. In the ED, they were also worried about possible aphasia, so she was activated as a stroke code. Her CTA, CT perfusion was unrevealing, so she underwent MRI. On her MRI, the astute observer might notice that her ear canal and adjacent soft tissues are abnormal on T2 on the left compared to the right. And following gadolinium, there's some pathological enhancement in her soft tissues as well as her facial nerve, but that's somewhat subtle. On the ASL, however, it's quite obvious that all of those soft tissues are hyperperfused and our attention is drawn to that area. So if somebody might have walked by it on those images, following ASL, they are not going to walk by it. And this patient ended up being diagnosed with herpes zoster oticus. So in summary, ASL is definitely ready for prime time in the head and neck, though much remains to be learned. Some of ASL is what I call pure genius, with fewer missed shunting lesions like dural AV fistulas and AVMs. In some ways, it just makes life easier, like our post-op or recurrent paraganglioma, where we probably would have analyzed the case just fine without ASL, but the ASL is helpful. But I really find it extremely interesting. So in summary, showing my Boston roots, ASL is wicked awesome. I hope that you also think ASL is wicked awesome, and I hope you've learned something with me today. With that, I thank you very much for your attention, and I truly hope that you enjoy the rest of the meeting. Thank you so much for your attention today.